So most of these lesions are reasonably easy to diagnose when they're classic examples, which you should get in your FRC path, to be honest. But I think it's always worth having in mind, when you get into the real job, pitfalls and difficulties, because that's what you really need to concentrate on when you're a pathologist. That particularly things which you can misdiagnose and it makes a difference to patient management. If you mix up some of the subjective benign entities, then arguably it doesn't make any difference anyway. So I've avoided that kind of thing in general. So,
Tim, just before you start, can I just double check that you're happy to be recorded?
Yeah, that's absolutely fine. Yeah.
Perfect. Thank you.
Have you started recording?
Yes.
Okay. That's fine. So we'll move on to the first slide. So normal anatomy. So as a pathologist, you don't really need to know the small print of anatomy, but you need to know roughly where the parotid is. So the parotid gland and duct here are in yellow. You can see it's sitting on the sternomastoid here, with the masseter at its anterior border. It's worth knowing about this accessory parotid lobe, because sometimes you'll get an FNA or a biopsy saying facial mass, or a facial lump. So you can imagine that is actually in the cheek, and that can present as both a submucosal and a subcutaneous lump. And you can also get salivary gland tumours that arise in the parotid duct. The parotid duct feeds into the oral cavity above the molar tooth on the upper jaw there. The other thing that's worth bearing in mind is, unlike the other major glands, the parotid has multiple lymph nodes in it. So you can actually get, lymphomas and also metastatic tumours arising and spreading into those intraparotid nodes. The other thing which you'll see a lot is salivary inclusions, and they can benign salivary inclusions can occur both in those intraparotid nodes, but also in nodes that come down into levels 2 and 3 down here, particularly along the sternomastoid here. One thing the radiologists don't see that we do see is that the parotid tail does spread down, come down this sternomastoid here, and you'll often see tumours, particularly Warthin's tumours and benign things, coming down into the neck here on the sternomastoid into levels 2 and 3.
You've muted yourself, Tim.
I don't know how I did that. Sorry about that. Oh, I think I must have pressed space, thinking that would move me on slides. I don't know. I hope you didn't miss too much of that. Anyway, so we'll now move on to the anatomy. Oh, why have I lost the anatomy of the? Oh, okay. I think what I'll do is I go into histology, normal histology, and then talk about anatomy of the other glands. So the normal histology, it has a lobular arrangement of the parotid gland. Quite a lot of the parotid parenchyma is fat, and as I've mentioned already, there's also lymph nodes in there as well. Now the arrangement of ducts is quite interesting. So within the lobule, you've got the serous acina cells, which have got these dark blue granules in them, which are the zymogen granules, which have the salivary enzymes in them, and they feed into this first duct that's the intercalated duct. This serous acinus is surrounded by myoepithelial cells, which you'd struggle to see on routine H&E histological section. But if you can imagine, like that each of those balls of serous acinar cells is like a tennis ball, and the myoepithelial cells are almost like the fingers of a hand that are squeezing that acinus and squeezing the saliva out of that acinus. In fact, if you look at them ultrastructurally, the myoepithelial cells around the acinus are just like that. They're almost like a spider shape. The myoepithelial cells also surround the intercalated ducts, but they're more fusiform in shape. There's probably one there. You need immunohistochemistry to tell for sure. And then you've got the striated ducts. You can see they've got a lot of pink cytoplasm. They almost look like oncocytic cells. But that's because they've got a lot of metabolic activity. They're full of, they're not actually oncocytic cells. This is the normal appearance under the microscope. So they're full of they've got a lot of metabolic activity and mitochondria, and so that's why they have that appearance. They also, if you look at them ultrastructurally, the mitochondria are arranged in little striations at the base of the cell, so that's why they're called the striated ducts. They've also got myopithelium surrounding them. And then finally you get to the excretory duct, which is in the center here in this picture. And that isn't surrounded by myopithelial cells, it's surrounded by basal cells, but we can still pick those up with immunohistochemical stains. Now, this is going to become important when we start talking about entities, and I'll tie it in at the end to show you how neoplasms of the salivary gland can all be tied back to this microanatomy, and that that they effectively arise or differentiate towards the different cells, either in the acinus, the small intercalated ducts, the striated ducts, or the excretory ducts, and their basal and myoepithelial cells respectively. So the normal anatomy and histology of the submandibular and sublingual glands. So you can see the submandibular gland down here at the edge of the jaw, which is bordered by the mandible masseter, the digastric muscles here, anterior belly and posterior belly of the digastric, and then the mylohyoid, which is like a sheet of muscle which the sublingual gland sits on. Remember that this sheet of muscle can sort of have a defect in it, and there can be herniation of the sublingual gland, or at least its mucous contents, and that can plunge down into the neck, and that's called a plunging ranula. So the submandibular gland is a mixed gland, rather than the when we talked about the parotid gland, which is all serous acini. The submandibular gland contains a mixture of these mucous acini, which are the ones with the pale grey cytoplasm, and the serous acini. And then this is a higher power. The sublingual gland is about 80% mucous acini, and the submandibular gland has roughly 50-50 serous and mucinous acini. Now, we love sort of these little obscure names. There's these little caps of serous acini that are called serous demilunes. So you only see those in the submandibular and sublingual glands. And you only see it that way around. You see the serous cells on the outside and then the mucous cells on the inside. And this allows the saliva to have both a mixture of serous and mucinous contents. The smaller the gland gets, the more mucus the contents are. And then minor salivary glands that are all virtually all mucous acini. You can see they still have this lobular arrangement, but unlike the major glands, they don't have a capsule, so they just merge into the surrounding connective tissue. Most of them are in the oral mucosa, palate, base of tongue, and the lips, for example, and that's why you can get these minor salivary gland tumors that occur pretty much anywhere in the oral cavity. The lack of a capsule can make it tricky for pathologists sometimes to identify whether there's actual invasion of the surrounding tissues or whether it's a benign tumor with a pushing border. So there's thousands of these minor salivary gland lobules and units in the oral mucosa, but you also get them in the upper aerodigestive tract. So that's why you can get things like, pleomorphic adenomas in the bronchus, for example, or adenoid cystic carcinomas in the lacrimal gland, for example. And the general rule with the tumours is the smaller the gland, the more likely it is to harbour a malignant tumour. So that's where I move on to the rule of 80s, which I learned as a surgical trainee, but I think it's quite a useful rule of thumb. So 80% of salivary tumours are in the parotid. 80% of parotid tumours are benign. 80% of benign parotid tumours are pleomorphic adenomas. And about 80% of sublingual and minor gland tumours, conversely, are malignant. And then there's this bit about the salivary stones as well. Most of them form in the submandibular gland. So first case I'm showing you is quite a nice example of a beautifully smeared FNA slide from a long-standing parotid lump in an elderly lady. So zooming in, we've got this metachromatic or sort of purplish coloured stromal material, which is fibrillary in its appearance. And then you can see perhaps some ductal cells down here and some blue cells scattered around, both within the stromal material and surrounding between the stromal clusters. And if we zoom in, we've got here in this picture the ingredients of the diagnosis of pleomorphic adenoma on cytology. So we've got fibrillary stromal material. It's important that it is fibrillary. It's not mucus, or some of it can look a little bit, there are mimics, which we'll move on to. You've got myoepithelial cells, which a little bit like fibroadenomas in the breast, they often have this sort of lemon-shaped appearance, very scanty cytoplasm, and these need to be scattered around. If you can see these scattered around in the parotid FNA, you can be pretty confident that it's going to be a pleomorphic adenoma. And you want to see these both scattered around and also within the stromal clusters, not pushed to the edge of the stromal clusters. You want them to actually be admixed, and that's a reassuring feature. And then you also want some epithelial cells scattered around, like ductal cells, for example. And those three components will enable you to make a confident diagnosis of pleomorphic adenoma. So what about spitfalls or pitfalls in a pleomorphic adenoma? It's often not the case that you get that beautiful appearance with lots and lots of stromal material. Sometimes you can get myoepithelial cells as the predominant player in these lesions. So, this one was one with nearly all myoepithelial cells that often have got a plasmacytoid appearance as well. Myoepithelial cells are the great mimic. They can be spindled, they can be epithelioid, they can have all kinds of shapes and sizes. And perhaps in a FNA like this, you might want to go sump rather than go straight for pleomorphic adenoma, depending on the clinical ultrasound features. You can have some sort of chondroid differentiation. You can have areas that look a bit mucinous like this. Some of the epithelial and myoepithelial cells can almost have the appearance of keratinization, which can be concerning. It's pretty common to have large pleomorphic nuclei like this. It can be a marker that it's malignancy occurring in a pleomorphic adenoma, but you also get anisonucleosis, which is benign. And then sometimes you get these spherical balls of stromal material, which are non-fibrillary and remind you of other lesions which are more significant, and we'll move on to. And the reason why you get this heterogeneity in FNA smears is that you get heterogeneity in the macroscopic appearance of pleomorphic adenoma. So this is really the classical appearance. This is a superficial parotidectomy, and you've got this lobulated, sort of almost raw potato cut surface, often with these little knuckles of tumor which extend into the surrounding fat. And if the surgeon just shells out the tumor, then these knuckles can stay in situ, and the patient will get a recurrence. On the other end of the scale, you have ones which are almost all epithelium. And so in these ones, you get an appearance of the cut surface of the tumor, which almost looks like the normal salivary gland. And you might need to look quite carefully to find a little chondromyxoid area like this, which gives you the diagnosis of pleomorphic adenoma when you look at the histology. Just checking you can still hear me okay? Yeah.
Yep, perfect.
Good. So this is your sort of more classical appearance of, which I might have grabbed from the lead site. So this is obviously all serous acini, so this is parotid gland. And in the center, you've got this tumor, which even at very low power, you can tell has a lot of chondromyxoid material and also ducts and some sort of more solid glandular areas. In contrast, you've got this one here, which is much more blue, contains nearly all epithelium and myopithelium. And then you've got some tiny foci of chondromyxoid material like that, which you might need to take several sections for, or even embed the whole lesion in order to identify. There's something a bit unusual about this one as well, as if you zoom in, there's your chondromyxoid material. But if you look here, this is quite a lot of squamous differentiation here. And if you just got that on a biopsy, it might be pretty scary. You might think of squamous cell carcinoma, but in fact, this was in the needle tract, and it's just some squamous metaplasia in the needle tract. And if you looked at that slide online, there was a bit of hemorrhage in there as well. So that's benign. So which of the following statements regarding pleomorphic adenoma is true? Carries nearly zero risk of recurrence or malignant transformation. Hands up for that one. I'm sure no one's going to put their hands up for any of these. Characterized by architectural diversity and is composed of only one single type of cells. Is the most common salivary gland neoplasm. And then number 4, typically treated with enucleation. And of course, the answer is it's the most common salivary gland neoplasm. It doesn't have a near zero risk of recurrence, which we'll move on to. It does have architectural diversity, but it also has several different types of cells in it as well. And it most definitely shouldn't be treated with enucleation unless, it's a 90-year-old who wants to get rid of it, because it will recur. So it's the most common salivary gland tumor. It has triphasic differentiation. So it has epithelial, ductal cells, myoepithelial cells, and this mesenchymal material, chondromyxoid stroma. And for this reason, you can get lots of variation in the appearance, as I pointed out already. In fact, you can even get sarcomas appearing in pleomorphic adenoma. So it occurs at all ages. You do get these in very young people indeed. There's a slight female predominance. I put benign in inverted commas because if you get a surgical resection with a negative margin, it is curative. Enucleation, though, is associated with quite a significant risk of local recurrence, and those local recurrences can be up to 50 years later. And the risk of malignant transformation actually is higher in people that have had local recurrences. So if it's just enucleated and then you get recurrences, then your recurrences and malignant transformation chance goes up, and they tend to be more aggressive when you do get a malignant transformation. Prominent hyalinization, this is something I didn't know until I started looking this up. If you get increased mitotic rate, it's not necessarily a worrying factor, but I would say sample more thoroughly if you do see it. Someone's got their hand up. Is that an old hand, or is there still a question that's wanting to be asked? No? Maybe the hand was up for the question, that's fine. Right. So I might have got the case numbers wrong for this. It's quite likely because I did this in a bit of a hurry and I haven't been through the slides yet. So sorry about that. So case for 68-year-old male, long-standing lump in the cheek, started growing for the last 3 months. First thing I want to show you, pay your attention to, is this sclerotic nodule here. And then you can see that there's cellular tumour extending out from the gland into the fat. You can see there's a bit of residual normal gland there at low power examination. And if you zoom into that area, you can see that there is tumour which has been cut through here at the edge. And then there's this odd hypocellular area up here. This is actually carcinoma ex pleomorphic adenoma, and we called this one adenocarcinoma, not otherwise specified. So you can see that this is an invasive adenocarcinoma. It's got a stromal desmoplastic response, and it's formed of tubules. There's no specific differentiation, so we use just adenocarcinoma, not otherwise specified in this. This was high grade, but you can see that this was arising in this sclerotic area, and the history suggested carcinoma ex pleomorphic adenoma. This is another case that was one of those ones, like I said, that I ended up going back and taking more sections because I found this little abnormal area which just looked a bit different. We'll zoom into that. So it was more cellular than the surrounding tumour, and when I zoomed in, there were multiple mitoses, it was pleomorphic, and it looked worryingly like ductal carcinoma of the breast, for example, which is known to arise in the salivary gland as well. And it is one of the most common carcinomas that you get arising in pleomorphic adenomas. It has a very high rate of HER2 upregulation, so HER2 3+ on immunohistochemistry, and also the tumour cells were androgen receptor positive. So testosterone receptor equivalent of about 7 or 8 out of 8 using the breast scale. So regarding carcinoma ex pleomorphic adenoma, fine needle aspiration is a highly sensitive technique for the diagnosis of this entity, true or false? Number 2, malignant transformation is equally likely to occur in a primary pleomorphic adenoma as it is in a recurrent pleomorphic adenoma. We've already mentioned that that's not the case. It's much more likely to occur in a recurrent pleomorphic adenoma. It's not always possible to identify the pre-existing pleomorphic adenoma macroscopically. This is definitely the case. Now, you could say this is a bit academic, but I personally, if I get a history that sounds like carcinoma ex pleomorphic adenoma, then I try my best to find the original pleomorphic adenoma. And that, usually requires putting the entire tumour through, in fact, putting the entire specimen through, and sometimes doing multiple levels as well. Sometimes it'll be sclerotic, as we saw there, and sometimes you'll see some chondromyxoid stroma and perhaps some benign-looking glands in it. Submandibular gland is the most common site of origin. No, that's not correct. It's carotid. So the correct answer is this one, number 3. So it's not always possible to identify the PA, and recurrent PA has a higher risk of malignant transformation. FNA has a low sensitivity for detecting carcinoma ex pleomorphic adenoma. It obviously depends on where you stick the needle. So you can get epithelial carcinomas, like I've showed you already, like a ductal carcinoma and adenocarcinoma NOS are the most common malignant subtypes that occur in pleomorphic adenoma. Rarely you can get sarcomas ex pleomorphic adenoma. So you can get something like a chondrosarcoma, for example. You could get a sarcoma not otherwise specified in a long-standing or recurrent pleomorphic adenoma. And this is important. It's stratified on the extent of capsular invasion. So that second example I gave you, an intracapsular carcinoma ex pleomorphic adenoma, is arguably benign. So you don't want your surgeons to be talking about neck dissections for these. If that's out, it's within the pleomorphic adenoma, don't worry about it. Report it, but make it clear in the MDT that this is not anything to worry about. You've put the rest of the specimen through, there's no spread out of the capsule, it's going to behave like a benign pleomorphic adenoma. And then you've got minimally invasive, which is less than 1.5 millimeters beyond the pleomorphic adenoma. And then you've got widely invasive, which only actually is 1.5 millimeters and beyond. So there's a low threshold for calling something widely invasive. They're commonly HER2/3+, which can also give you a therapeutic option. We've got patients that have had Herceptin and have had local control for quite a number of years that have been HER2/3+. And also you can use androgen blockade. So you can use certain prostate cancer drugs to treat these patients. They often correlate with mutant p53 and also this tumor suppressor gene PLAG1, which is this one here, giving you a reference. So moving on to Warthin's tumor. So this is the second most common benign tumor after pleomorphic adenoma, and this is truly benign. If your surgeons diagnose this and want to leave it alone in an elderly patient, that's perfectly fine if you're confident with the diagnosis. It's more common in males and it's more common in smokers for some reason. We don't know why. It tends to occur most commonly in the parotid and particularly the tail. So you might get these cropping up in what the ultrasonographer might describe as level 2 in the neck. It's actually the tail of the parotid that sneaks down alongside that nodal chain. As I mentioned already, you get these salivary ductal inclusions in lymph node, and that is meant to be the origin of intranodal Warthin's tumors, which can cause some diagnostic problems just for radiologists, clinicians, and pathologists. And the very low power appearance is this sort of papillary appearance where you've got a dual layer of oncocytic and basal epithelium surrounded by a cuff of dense lymphoid stroma. The cystic fluid, which can be variable, sometimes these are predominantly cystic, sometimes they're predominantly solid, contains some sloughed off epithelial cells, and these can sort of round up and look a little bit scary sometimes on a cytology smear, so that's worth bearing in mind. And reports of malignant transformation are dubious. I don't really believe that these turn malignant. One of the possible reasons is there's something called a Warthin-like papillary thyroid carcinoma. And you can see how much this looks like Warthin's tumor. It's got a lymphoid cuff. It's got this sort of oncocytic-looking appearance of the epithelium, but it doesn't have a dual layer. And actually, it's got papillary thyroid nuclear features as well, the orphan anes, the sort of rounding up. This is probably a variant of tall cell papillary thyroid carcinoma, which you may well have talked about with Effie, I'm not sure. Thought about this. So this was an elderly male smoker with what they described as an infected parotid mass. When I cut this in half, it looked a little bit like an abscess. There were these yellow bits and calcification, and it looked like a chronic abscess. But the previous FNA was confidently called Warthin's tumor. But when I cut sections of this, there was a lot of necrosis, and then there was this rather scary looking squamous epithelium, which in areas looked quite infiltrative as well. So what would you do here? Well, my first instinct was to just check that we hadn't misdiagnosed the previous parotid FNA. So I got that out of file. It was cellular, and it contained nice, well-defined epithelial groups like this on a cystic and lymphoid background. And zooming in, these were nicely arranged oncocytic cells with not too much overlapping and monotonous. I was very confident that that was consistent, entirely consistent with the benign Warthin's tumor. So I went back to the specimen again. I put it all through and also did some immunohistochemistry. And that was actually reassuring. You could see that there was, if you really did the low molecular weight cytokeratins, you could see that there was a dual layer there, even though you couldn't see it morphologically. The immunohistochemistry helped highlight that there was a dual layer, and this was just squamous metaplasia in a Warthin's, albeit florid. I've never seen one quite like this before. But it's the known infarcted or metaplastic type reported in histopathology. So Warthin's tumor is a source of false negatives and false positives on FNA, so plenty of spitfalls. So we've got a wolf in sheep's clothing and a sheep in wolf's clothing. So it can be either. So your specimen typically has a capsule, and then it looks like a partly cystic lesion. The fluid, when I used to do FNAs of these, and you look at it, hold it up to the light, it can look like machine oil. It has little glinting, sort of gold glinting flecks in it, which are thought to correspond to cholesterol clefts within the fluid. And then you've got the normal salivary gland tissue around the outside. So as I've already explained, you get these papillary structures lined by oncocytic dual layer of epithelium, and then you've got this lymphoid cuff, which permeates these papillary structures. The concern really is when you get cells like this, you get these kind of hyperchromatic, slightly squamoid appearing cells. So you want to look around and just make sure they're not too numerous, and you want to see groups like I've explained there. Unless I see things like that, then I tend to go equivocal with them, because it's just known that you can get these things wrong. There's no point in being too cocky. And the other thing that can be tricky is that Warthins can be multifocal, bilateral, and even intranodal. They're extremely avid on PET scans as well. So it's probably the most common incidentaloma these days. If you do a PET scan, you're almost bound to, in an elderly male, find a Warthin's tumor as well. And then they end up needing to be taken out, or at least FNA'd. Right, so this one was a 60-year-old female with a parotid mass FNA. I must admit, I think we sumped this one. I think we put this in the equivocal category. It was quite pleomorphic. There was a bit of overlapping. There was a bit of a cystic background, but it didn't have the sort of lymphoid background of a typical Warthin's. I picked on these two groups particularly because there was quite a bit of an isonucleosis, but I wasn't convinced that it was overtly malignant. And there were a few ductal cells around as well. And when this was cut out, it actually has turned out to be a benign oncocytoma. This is actually has got a central scar, which might be to do with the previous FNA. But as it's known in renal tumours, you can get a central scar in salivary oncocytomas as well as renal tumours. So oncocytoma, really, if you mix up oncocytoma and Warthin's tumour on FNA, I would say it doesn't matter too much. They're both benign, and they're composed of oncocytes. They can be called oxyphil adenomas. They're pretty rare, actually. Probably see them about once or twice every few years. They share some characteristics of Warthin's tumor, including multifocality, and they're very prone to infarction. So if you stick a needle in them, they can actually infarct. Unlike Warthin's, they have a much cleaner background, and you don't get a dual layer. Sometimes in a FNA, particularly in the clot preparation, you can actually appreciate the dual layer. So that can help you distinguish Warthin's and oncocytoma, if indeed it's important, which I'm not convinced it is, to be honest. This was another one which was called Warthin's tumor, but turned out not to be. You shouldn't have these loosely cohesive cells with overlapping and hyperchromasia in a Warthin's. They shouldn't be rounding up like this. And there's also was a group that looked a bit cribriform here as well. And this one turned out to be salivary intraductal carcinoma. So this, you can see it really closely resembles DCIS in the breast, which I haven't seen for about 10 or 15 years, but I'm told that it looks like it. It requires thorough sampling to rule out invasion and the presence of a myoepithelial layer. So this is contained within a myoepithelial investing layer. And although even when it's high grade, it tends to behave in an indolent fashion. This was actually quite a young woman who'd had a long-standing parotid mass, and she eventually had it excised, and she's had no recurrence since. My understanding was that was there for about 7 or 8 years before it was taken out. Now, I have seen 1 or 2 cases of high-grade salivary duct carcinoma, misdiagnosed as Warthin's on an FNA. They're often oncocytic in appearance, the malignant cells, but they're loosely cohesive. There's a lot of overlapping, very cellular smears, and you want to be calling this malignant if you see it on FNA. That corresponded in this particular case to a tumor with this oncocytic appearance. Really looked like an oncocytic adenocarcinoma, which is kind of what it is. Sometimes they do have an investing myoepithelial layer in area, sort of an introductal component, but the majority of the tumor around the edge was truly invasive like that. And again, we've got positive androgen receptor and HER2 immunohistochemistry. This is another FNA, which was from a 40-year-old female, a small painless round tumor on ultrasound. I must admit, when I look at this, it reminds me of follicular cells from a thyroid FNA. If you look a bit higher on the clot preparation, you just get the impression the cytoplasm is quite granular on these. And in fact, here you can see zymogen granules. So I hope you're thinking that you would do a PAS stain and identify the zymogen granules as being positive, and this is actinic cell carcinoma. The pitfall for this would be sometimes you get sampling of normal acini in a parotid FNA, but normal acini, you wouldn't get a group. If you start to get groups this sort of size, there should be some fat cells, and you'll also see some duct cells as well dotted around. This is too much, so this has to be a actinic cell carcinoma. So the actinic cell carcinomas can be very indolent. They can be very small. Often they look like a pleomorphic adenoma to the ultrasonographer, and they're thought to be benign. They can be sat on for a long time. I would say most of them that I've seen have behaved indolently, and they're excised. They have a scan. There's no nodes involved, so they just treat them with clinical follow-up and ultrasound. On the other hand, and you can see here these nice zymogen granules on the H&E would be highlighted nicely on a PAS if you did that. They often have quite a dense lymphoid cuff. The ones with the lymphoid cuff, this one doesn't here on the left. Ones with the lymphoid cuff tend to have a better prognosis. So if you see a lymphoid cuff on an actinic cell carcinoma excision, then mention it. This was a case from a few months ago of a woman who presented with an aggressive-looking mass in the neck. And this was an actinic cell carcinoma with high-grade transformation. I think you can just about see that there's still zymogen granules even in this high-grade tumor, despite the presence of necrosis, multiple mitoses, etc. And it retained DOG1 positivity, which is classically seen in actinic cell carcinoma. We also did the NR4A gene rearrangement break-apart FISH, which was confirmed on this particular case. So actinic cell carcinoma, there's a nice picture of the DPAS with the zymogen granules up on the top right. It's a malignant salivary gland tumor with serous acina differentiation. It's most commonly the parotid. It's usually well defined, and the clinical behavior tends to be indolent unless there's high-grade transformation. It's obviously stage dependent and whether there's any nodes involved. DPAS positive zymogen granules, to be honest, I would just diagnose this on a well-differentiated tumor on the H&E. The DPAS is a good one to do. Personally, I don't think it's necessary to do cytokeratins because the differentiation is usually so good and it's usually so obvious. Sometimes you might want to exclude secretory carcinoma, which is DOG1 negative and has a characteristic NTRK ETV6 translocation. I've only seen one of these before. In fact, when secretory carcinoma was first sort of appeared in the WHO classification, I looked back through my logbook and I found a couple of actinic cell carcinomas that I'd made a few years previously, and I pulled them out, and one of them was a secretory carcinoma. They look pretty similar at low power examination. So the proposed actinic cell carcinoma grading system is low to intermediate grade with low mitoses, less than 5 per 10 hypofields, and no necrosis, and then high grade, any necrosis and a higher mitotic rate. This was actually an FNA that I remember quite well because I did it myself, and I made the poor lady cry. But afterwards, I kind of found out why. So she was young lady. She had this lump on the angle of her jaw, which looked like it was in the superficial parotid, and she said it was like an electric shock pain. And she was a military worker, so it was pretty tough. And there were these balls of stromal material, really well defined, sort of cookie cutter appearance, and then the cells are quite hyperchromatic. The epithelial cells, you don't have. These are lymphoid cells. You don't have very nice sort of myoepithelial cells, plasmacytoid cells floating around. You've just got these angulated cells that are generally separate from the stromal material. And this was the histology, this cribriform pattern, and importantly, a dual layer with most of the immunohistochemical markers. You can see there's P40 is showing a peripheral pattern of the basal myoepithelial cells surrounding the ductal cells. SMA is also staining the myoepithelial layer and not the luminal layer. CD117 is staining the luminal layer and not the myoepithelial layer. And interestingly, P16 sometimes stains these as well, just the luminal layer. It's non-HPV related. This was a different patient that we saw a couple of years ago, but he keeps on getting recurrences. He actually had a lacrimal gland tumor, which, when it was excised with the temporal bone, showed extensive invasion of the bone, including Haversian canal invasion, which is pretty rare. And this is a classic appearance of adenoid cystic carcinoma with peripheral myoepithelial cells, which you can actually see on the H&E. These got a slight pale rim of cytoplasm and these quite angulated myoepithelial cells, and then a separate luminal layer. Pretty monotonous looking, certainly not high grade, but of course the classic feature in adenoid cystic is this extensive perineural invasion. And I think it's quite a good rule that people say, if you don't see perineural invasion, then it's not adenoid cystic carcinoma. I'd probably check that, when you do your FRC path examination. If you think something's adenoid cystic, look really hard for perineural invasion. It'll be there. So it's a common malignant salivary gland neoplasm. It's got biphasic morphology. It occurs in the major and the minor glands. And in that previous example, it's also the most common lacrimal gland cancer. You can get them in bronchi and almost everywhere, really, skin. It has a devastating clinical course, particularly the salivary gland type. It usually presents as a low-grade tumor initially, but it has this horrible stat, which certainly I would agree with, 100% recurrence. So they always recur, and they can recur 10 or 20 years later. And they often present or represent in the cranial nerves with horrific perineural invasion. So I showed you that one with the positive P16. It's non-HPV related. There is a sinonasal adenoid cystic-like carcinoma, which is HPV related. So it's worth considering that if you're looking at it in a different place like the sinonasal tract. Most of them have a characteristic fusion involving MIB. And you can actually do a MIB immunohistochemical stain, but I tend to send them away for fish. And there's some other genes that are also involved. People get quite excited about CD117. Personally, I would be a bit careful about CD117. It's a non-specific marker. If you do CD117, then check it is actually staining the luminal cells. If you get a wishy-washy positivity, you can get that in almost any salivary gland tumor, and I would ignore it, to be honest. So adenoid cystic carcinoma must have a dual layer, very important, and it doesn't have KIT mutations. So this is another one. Initially, I thought this might be adenoid cystic carcinoma. Those two pictures on the left could easily be adenoid cystic carcinoma. So you've got cookie cutter stromal material, you've got hyperchromatic myoepithelial cells surrounding those cookie cutter basement membrane material clumps. But you've also got some areas that look a bit more like pleomorphic adenoma. You've got more fibrillary stromal material and some dispersed myoepithelial cells spreading around as well. I just managed to find one area where the cells had a clear cell appearance like that. And this turned out to be epithelial myoepithelial carcinoma. Classic macroscopic or low power histological appearance is quite like pleomorphic adenoma, actually. In fact, in this particular case, there was a sclerotic center to the tumor, which may well have represented an old pleomorphic adenoma. So this is a carcinoma which can arise in a pleomorphic adenoma. And this is the classic appearance you get with these really clear myoepithelial cells surrounding a rim of ductal cells. The nuclei are different to adenoid cystic, so you get nice round, more epithelioid, classic epithelioid myoepithelial cells, whereas in your adenoid cystic, they tend to be sort of triangular and hyperchromatic. And this is a classic appearance. They don't always look like this, unfortunately. Sometimes you can have them with quite pink cytoplasm. Chris Lung in Exeter sent me a case recently, which was, I thought, a classic epithelial myoepithelial carcinoma, but I only found a tiny area of clear cell chain. The immunohistochemistry is effectively the same as adenoid cystic, with this peripheral rim of myoepithelial cells picked up with basal and myoepithelial markers. So epithelial myoepithelial carcinoma, it's a malignant biphasic salivary gland carcinoma, generally has an indolent clinical course, and it's presumed to be of intercalated duct origin. Most of them carry HRAS mutations. And as I mentioned, a subset can occur as a carcinoma ex pleomorphic adenoma. It always has an outer layer of myoepithelial cells. They're usually clear, but they're not always clear. It lacks a cribriform pattern and angulated myoepithelial cells of adenoid cystic carcinoma. So I would say, if you look at something with dual layer and has some clear myoepithelial cells, just always consider adenoid cystic versus EMC. Have we got any questions at this point? Having a little slurp of my drink here. Julia, is that a question from you?
No, have I got my hand up?
Got your hand up. That's fine. Sorry. Okay. Put that back up again. So minor salivary glands. This is not exhaustive. It just happened to be a few cases that I'd seen recently. This was a lady in her 40s that had this rather worrying-looking ulcer, but down to the bone on her hard palate, and the biopsy looked like this. If you zoom out, there's this ulcer, and you can see cells that are showing squamous differentiation, and then cells with more classic minor salivary gland differentiation merging back into squamous differentiation at the edge of the biopsy there. He was an ex-smoker who did a lot of vaping, apparently, and was asthmatic on multiple medications, including inhalers. Oh, that's annoying. That was meant to show you the low power appearance. And I think the low power appearance here is really helpful, because this is actually benign. This is necrotizing silent metaplasia. You can just imagine that when you get a small biopsy of this, through here, for example, that you could easily be fooled into thinking this is squamous cell carcinoma. Particularly ugly clinical appearance sometimes as well. But this is benign and self-limiting, necrotizing silent metaplasia. It mimics malignancy both clinically and histologically, but resolves spontaneously in 3 to 12 weeks. I've seen these most commonly in patients that have had previous radiotherapy, and then of course you've also got the risk of recurrence to factor in. So you can have someone who's had previous squamous carcinoma, they've had radiotherapy, and then they get necrotizing silometaplasia. And that's one of the hardest diagnostic problems that we encounter, I think. So it can closely resemble SCC and mucoepidermoid carcinoma on a biopsy particularly. So this is a notorious salivary pitfall. So the lobular architecture at low power examination, and like a lot of things in pathology, is just thinking of it. You know, make sure you remember this lesion and think about it before you make a confident diagnosis one way or the next. You know, and sometimes the biopsy is too small and you just have to ask for another biopsy. Usually hard palate. It's thought to be ischemic etiology, so you do get them in smokers, vapors, and people that are on multiple medications. This was another one which I think I might have given you the digital slides too, which is probably only had this a couple of weeks ago. It was described in the mucosa as a cyst. It was a young man. And you can see here that there's the normal minor gland over here. And you've got this tumor which certainly has lots of cysts in it. And zooming in, you've got these sort of squamoid cells, but also multiple cysts and mucus cells, which show up nicely on the Alcium blue PAS. It's CK7 positive. If you looked at the squamous markers, they'd show some patchy positivity as well. The S100 is negative. There just happened to be a nerve at the bottom there, so I took that. This is not a myoepithelial salivary gland tumor. It doesn't show any myoepithelial differentiation. And that's the Ki67, which was negligible. So this is a mucoepidermoid carcinoma. It's the most common malignant salivary gland tumor in children and young adults. It's composed of mucus cells, intermediate cells, and epidermoid cells. It doesn't show true squamous differentiation, so there shouldn't be any whorls or pearls, but you can get clear cells. And clear cell mucoepidermoid carcinoma is always a tricky diagnosis to make. There are multiple differentials. As you know, clear cells can be found in any kind of tumor anywhere in the body. Mucoepidermoid carcinoma is actually slightly more common in the major glands. You do see it in the parotid quite commonly. And actually, one of the tricky scenarios that you see mucoepidermoid carcinoma is within the wall of a cyst. So you might get a parotid cyst, for example, and they take it out, and just look carefully at the wall of the cyst and just make sure there aren't any mucus cells and intermediate cells in it. Most of them have this characteristic mammal tooth fusion, and again, you can look at that on break apart fish and send that off if you don't have it locally. The grading is really quite subjective. I would say most of them, nearly all of them, end up as low grade. But the AFIP grading system, I think, is the easiest one to understand. You know, unless you're seeing lots of mitoses, anaplasia, or necrosis, then they tend to be low grade. But it's not one you can eyeball generally. We talk about the sump dump quite a lot. So you put things in salivary gland tumor of unknown malignant potential, and in my experience, mucoepidermoid carcinoma does end up there quite a bit. This was a good example of one which had quite big groups of cells that were overlapping on the pap. And, you know, you just get the impression there's some mucus cells here. You know, I've occasionally done a restained ABPAS, which can be useful to highlight the mucus cells on a FNA. But I think it's another one of those ones that you've got to think about. You know, if you get a parotid cyst, then, and your first impression is it's probably benign, just think about mucoepidermoid carcinoma, look for those mucus cells. Particularly if it's a child, because children get these. I've seen these in, 6 or 7-year-olds. And sometimes in major glands, sometimes in, odd places like the upper lip and things like that. This is rare, but Muna's, I think, joined this. We got this case together. First of all, you get the section, it looks a bit like mucoepidermoid carcinoma. You've got sort of squamous and intermediate cells and these mucus cells as well. However, unlike mucoepidermoid carcinoma, it tends to be a well-defined cyst in the jaw, and often displaces teeth as well, which you can see on this panoramic OPG. We did the mammal2 on this and it was negative. It's worth bearing in mind that you can get intraosseous mucoepidermoid carcinoma, so that's another pitfall. You've got to really be able to look at the x-rays, you've got to be able to see whether this is arising primarily in the mucosa, and occasionally reach for these molecular tests as well. This one, again, I just had this a few weeks ago, but I thought was quite a classic case. It was an upper lip tumor that was slowly growing in an elderly man, and it has quite a polymorphous appearance. So you've got some quite well-defined tubules here forming lobules, and then here you've got this almost targetoid pattern spreading around this nerve here. In some other areas there were some more oncocytic cells, but the nuclear morphology is quite monotonous. The immunohistochemistry is really useful for this. So the S100 is staining that nerve in the middle, but it's also staining the tumor in a uniform pattern. There's no biphasic morphology here. This is every single tumor cell is staining for S100. Every single tumor cell is staining for SOX10. Every single tumor cell is staining equally intensely for CK7 and other cytokeratins. What's interesting with this tumor is you get this so-called anomalous pattern with P63 and P40. It's P63 positive and P40 negative. There's an internal control on the P40 with some basal cells lighting up. So this is polymorphous adenocarcinoma. It used to be called PLGA, or polymorphous low-grade adenocarcinoma, but in the most recent WHO, it's called polymorphous adenocarcinoma, acknowledging that you can get high-grade variants of this. But it is usually low-grade. I would say nearly all of the ones that I've diagnosed have been either palate or upper lip. The hardest differential for me is an incisional biopsy, which looks a bit like a pleomorphic adenoma and a bit like this. And sometimes the diagnosis is not possible to resolve. Generally has an excellent prognosis, apart from high grade, or what's this called, this new-ish entity called cribriform adenocarcinoma of the minor salivary glands, which is a variant of polymorphous adenocarcinoma. It has, and this is the rule for polymorphous, it has architectural diversity and cytological uniformity. Or can you think of another tumor that has this? Pleomorphic adenoma. So be careful. Like I say, I'll just emphasize this again and again. The hardest diagnosis in head and neck pathology is polymorphous adenocarcinoma versus pleomorphic adenoma. The difference is, and people forget this, you only get this in minor salivary glands. Okay, so don't try and diagnose polymorphous adenocarcinoma in the parotid. You don't diagnose it there. So this anomalous pattern, P63 positive, P40 negative, and it's always one population of cells. So it's not a biphasic like adenoid cystic. This pattern is really useful when you've got cribriform pattern polymorphous, or the cribriform variant of polymorphous adenocarcinoma. Oh, sorry. So this targetoid arrangement and streaming of tumor cells around nerves and vessels is very common, and perineural invasion is also pretty frequent as well. Despite this, it generally has a good prognosis. This tumor suppressor gene generally tends to have hotspot mutations, whereas in the next variant I'm going to show you, it tends to have translocations, but in the same gene. So this is why they're probably going to end up being separate entities in the future. So this is a cribriform variant. This is one that I diagnosed back in 2013 in a lady that was, she was a professional singer. She presented with proptosis, and she had this huge palate tumor, which had been growing for years and years and years, and she'd neglected it. These are from a book, but this was her tumor that was invading bone. She's still free of disease. This is like 12 years now. The nuclei in this tumor really resemble papillary thyroid carcinoma. And in fact, one of the patterns that you should try and recognize in this tumor is papillary architecture, because papillary architecture pertains to a higher rate of lymph node metastasis. Well, this is one that Susie and I diagnosed recently, again, a palate tumor. And this behaved very aggressively. It was a late diagnosis. The lady had neglected it. And it showed extensive vascular invasion. Here's a vessel with tumor snaking down it. And this had quite good papillary thyroid nuclei as well. So I've kind of raced through this a bit. I apologize. I've gone a bit too quickly here. I thought this might take a bit longer than an hour, but I'm sure you'd be happy for an earlier finish. So this was just what I wanted to finish with, was that the variety of tumors that you see in the salivary glands are related, I think, to the histogenesis. So you've got this, as we talked about at the beginning, you've got the acinus, which is surrounded by myoepithelial cells, which obviously is the origin of acinic cell carcinoma, and then you've got intercalated ducts, which give rise to polymorphous adenocarcinoma, but also adenoid cystic, epithelial myoepithelial carcinoma, and secretory carcinoma. And then the striated ducts, which give rise to oncocytoma and Warthin's. The excretory ducts, which give rise to salivary duct carcinoma and adenocarcinoma. And then as this transitions into the oral cavity, where you've got mucous cells as well as squamous cells, you get mucoepidermoid carcinoma. And of course, pleomorphic adenoma can show almost all of these differentiations, but it's generally thought to be intercalated duct as well. Any questions? That's my backyard there. That's a couple of 100 meters from my door. That's what you get if you move to Cornwall.
Thank you very much. That was really